So, periostat and doxycycline, what does it do? Periostat is a sub-antimicrobial tetracycline. Is useful in treating moderate to severe chronic periodontitis. The active ingredient in periostat is doxycycline hyclate. In concern with scaling and root planning, there has been shown a treatment to be effective in institutionalized older adults. Periostat is contraindicated for those patients with an allergy to tetracyclines. Periostat is a tetracycline. We're gonna see a little bit more about periostat. Yes, periostat doxycycline hyclate. And what we find is that periostat, we're gonna do a quick check in the dex, in the periodex, periostat. Okay, in the dex we see that periostat the question is which of the following is the local delivery system of antibiotics accepted by the ADA and is available in the United States as a number of other countries. First option is doxycycline gel. Next question, 2% minocycline microspheres. Next, 25% metronidazole gel. And fourth, it's chlorhexidine 2.5 milligrams in gelatin matrix, which is a periochip. The answer is the only delivery system of antibiotics accepted by the ADA and is available in the United States and a number of other countries is 10% doxycycline gel. The limitations of mouth rinsing and irrigation have prompted research for the development of alternative delivery systems. Recently, advances in delivery technology have resulted in the controlled release of drugs. Subgingival doxycycline is one of them. Subgingival minocycline is another one. Subgingival metronidazole and chlorhexidine in a gelatin matrix. Now, subgingival doxycycline, the FDA approved 10% doxycycline in a gel system using a syringe known as Atrix Dox. It is the only local delivery system accepted by the ADA. Remember, the only local delivery system accepted by the ADA is the subgingival doxycycline, which is a 10% doxycycline in a gel used as a syringe, and it's called Atrix Dox. Now, the other drug is subgingival minocycline. The FDA recently approved a new locally delivered sustained release form of minocycline microspheres. It's called Arestin. Arestin is subgingival minocycline. Arestin. Um, and is an adjunct to scaling and root planning. This 2% minocycline is encapsulated into bioresorbable microspheres in a gel carrier. So you have your gel system, which is gel system syringe, which is atric dox and is doxycycline. Atric dox doxycycline. Okay, atric dox doxycycline, and you have your Arestin. Arestin is minocycline spheres in gel. Now the next one is subgingival metronidazole, which is a topical medication containing an oil-based metronidazole 25% in endo gel. It has been tested in a number of studies. This product is not available in the US. And chlorhexidine in a gelatin matrix, which is a resorbable delivery system that has been tested for the subgingival placement of chlorhexidine gluconate with positive clinical results. It's a small chip called period chip, composed of a biodegradable hydrolyzed gelatin matrix cross-linked with glutaraldehyde and also containing glycerin and water. 2.5 milligrams of chlorhexidine gluconate has been incorporated per chip. Systemic administration of antibiotics: tetracyclines, metronidazole, penicillins, cephalosporins, clindamycin, macrolides, and ciprofloxacin. These are systemic administration of antibiotics. The tetracyclines used to treat local aggressive periodontitis. They have the ability to concentrate in the periodontal tissues and inhibit the growth of Actinobacillus actinomycetin. Note: sub-antimicrobial dose doxycycline is a 20 milligram dose of doxycycline. Periostat, that is approved indicated as an adjunct to scaling and root planning in the treatment of chronic periodontitis. Periostat. Periostat is sub-antimicrobial dose of doxycycline. It's a 20 milligram dose of doxycycline. Periostat, approved and indicated as an adjunct for scaling and root planning in the treatment of chronic periodontitis. It is taken twice daily for 3 months, up to a maximum of 9 months continuous dosing. That's tetracycline periostat. Now, metronidazole is effective against actinomycins concomitants when used in combination with other agents. It is effective against anaerobes such as Porphyromonas gingivalis and Prevotella intermedia. Now, penicillins: amoxicillin and amoxicillin with clavonate potassium augmentin, and it may be useful in management of aggressive periodontitis, both localized and generalized. Cephalosporins are not often used to treat dental-related infections. Clindamycin used for patients with allergy to penicillin. Ciprofloxacin is the only antibiotic in periodontal therapy to which all stains of actinomycin concomitants are susceptible. And macrolides, which are erythromycin, spiramycin, and azithromycin. The only azithromycin is used and appears to concentrate in gingival tissues. Only azithromycin of all the macrolides is used and concentrates in gingival tissues. So that was about periostat. Okay, now next question. What is the bevel for occlusal on a crown used for? Bevel for occlusal on a crown. beveling provides? And the answer is structural integrity. Bevel for occlusal on a crown provides structural integrity. That is the need for the bevel to be placed on a functional cusp. So, let's see on Bart Busters some stuff about bevels. Well, there's a lot of material, so we're just gonna see it at its time, and we're gonna go with the next question. Closed panel go-to specialist, which would allow you to go to another dentist but reimburse you, HMO, PPO, etc. In the closed panel model, also known as the exclusive provider organization, the beneficiaries have a limited choice of offices where they can go to obtain dental care. If they go to offices not included in the panel, they receive no benefits. This model is often used in a DHMO or PPO plan. So I don't know anything about that. So I guess I don't know, we'll review that later. Increase in mucus from obstruction, cystic fibrosis. We're gonna study cystic fibrosis. So transmission, it is caused by a genetic mutation, which is a nucleotide deletion on chromosome 7, resulting in abnormal chloride channels. Cystic fibrosis, chloride channels, the most common hereditary disease in Caucasians. Cystic fibrosis. The genetic transmission form is autosomal recessive. Affects all exocrine glands. Organs affected include lungs, pancreas, salivary glands, and intestines. Thick secretions of mucus plugs are seen to obstruct the pulmonary airways and intestinal tracts. It is ultimately fatal. Diagnostic test is a sweat test in which sweat contains increased amounts of chloride. Next question. A patient has an increase in salivation. How does it affect the denture? There is no effect on the denture. Saliva lubricates the oral tissues and increases denture comfort. Next question. So, in the next question, we're gonna see it only says emergency phase, perio, reveal. Emergency phase, perio, reevaluation, fixed, and maintenance. Memorize this: emergency phase, non-surgical phase, maintenance, surgical phase, and restorative phase. How many canals will you find in a primary second molar? How many canals in a primary second molar? In the mandibular first molar, you will have 3. Mandibular second molar, 4. Maxillary first molars, 3. And maxillary second molars, 3. So only mandibular second molars, 4. Next question. Patient has had a denture for 19 years. Relief pain denture. Again, a denture for 19 years. A patient has pain in the denture area and a white spot. What do? Answer: relieve the denture in this area of the lesion and reevaluate in 1 week. Next question. A patient has successfully treatment for gum disease but still keeps poor oral hygiene. What kind of study is this? Incomplete. Next question. Null hypothesis. A null hypothesis, which is a hypothesis that there is no real difference between means or proportions of the groups being compared, or that there is no real association between two continuous varieties. That's a null hypothesis. There is no real association between two continuous variables. Variables. And there is no real or true difference between means or proportions of the groups being compared. Next, augmentin and clavulanic acid is combined to keep from degrading beta-lactam ring and forms augmentin. Amoxicillin is a bactericidal semisynthetic penicillin that is effective against both gram-positive and gram-negative microorganisms. It is susceptible to penicillinase, the penicillinase beta-lactamase. Amoxicillin is combined with clavulanate potassium augmentin, making augmentin, and is resistant to a number of penicillinases. How long do you take Coumadin, patient off Coumadin before surgery? Answer: 2 to 3 days. The international nitrogenous ratio INR is used to gauge the anticoagulant action of warfarin. Most physicians will allow the INR to drop to about 2.0 during the perioperative period, which usually allows sufficient coagulation for safe surgery. Patients should stop taking warfarin for 2 or 3 days before the planned surgery. On the morning of surgery, the INR value should be checked. If it is between 2 and 3, routine oral surgery can be performed. If the PT or prothrombing time is still greater than 3, oral surgery should be delayed until the PT approaches 3. Surgical wounds should be dressed with thrombogenic substances, and the patient should be given instructions in promoting clot retention. Warfarin therapy can be reassumed the day of surgery. Warfarin and Coumadin are oral anticoagulants that inhibit the biosynthesis of the vitamin K-dependent coagulation proteins, factors 7, 9, and 10. These drugs are bound to albumin, metabolized by hydroxylation by the liver, and excreted in the urine. Okay, warfarin and Coumadin are bound to albumin, metabolized by hydroxylation by the liver and excreted in the urine. The prothrombin time is used to monitor warfarin therapy because it measures three of the vitamin K dependent coagulation factor proteins, factors 7, 10, and prothrombin. The partial thrombin is particularly sensitive to factor 7 deficiency. The PT is particularly sensitive to factor 7 deficiency. Therapeutic anticoagulation with warfarin takes 4 to 5 days. The level of anticoagulation and need for altering dosage to avoid excessive bleeding. PTR 1.5 to 2 or NAR 2 to 3.0, 2.0 to 3.0. Dosage does not need to be altered. So if the partial thrombin ratio and the international natriuretic ratio does not need to be altered when PTR is 1.5 to 2 and INR it's 2.0 to 3.0. When the PTR is 2.0 to 2.5, the INR is 2.5 to 3.5. The dosage may be altered. And when the PTR is 2.5 or higher and the NAR is 3.5 or higher, there is need of delay invasive procedure until dosage is decreased. Decision is made to alter dosage of anticoagulation medication. Physicians will reduce the patient's dosage. After effect of reduced dosage takes 3 to 5 days. Dental appointments need to be scheduled within 2 days once desired reduction in PTR or NAR has been confirmed. For patients taking more than 325 milligrams of aspirin per day, aspirin may need to be discontinued 7 to 10 days before surgical therapy. Okay, so next. So benzodiazepine affects GABA. Note, benzos are minor tranquilizers that are used to relieve anxiety and induce sleep. Skeletal muscle relaxant. It depresses the limbic system and inhibits the neurons GABA-O, which is GABA aminobutyric acid on the chloride channels. Again, benzodiazepines affect GABA. GABA is a GABA aminobutyric acid. They are minor tranquilizers that are used to relieve anxiety and induce sleep. Skeletal muscle relaxant, and it depresses the limbic system and inhibits the neurons GABA-O. Next, albuterol. Albuterol is used for asthma. It is an expiratory wheezing. Asthma, the expiratory wheezing, which is treated by inhaler albuterol, which is a beta-2 adrenergic agonist. Other examples are metaproterenol, and salmeterol. Metaproterenol and salmeterol. It is also treatment for theophylline or the leukotriene called montelukast. It is also a treatment asthma is also treated by theophylline or the leukotriene called montelukast. In an office, if inhaler is not available, 1 gram can be used of epinephrine to treat anaphylactic shock. Next question. If a patient wants to last for 8 hours, which is the long-acting drug for pain? Aspirin, ibuprofen, acetaminophen. So, diflunisal is 3 to 4-fold more potent than aspirin as an analgesic and anti-inflammatory agent, but has no antipyretic properties. Diflunisal or Dolubid, which is the other name, is a bifluorophenyl derivative of salicylic acid. It is not converted to salicylic acid in vivo. Diflunisal, diflunisal, which is a difluorophenyl derivative of salicylic acid, is not converted to salicylic acid in vivo. Diflunisal is more potent than aspirin in anti-inflammatory tests in animals and appears to be a more competitive inhibitor of cyclooxygenase. However, it is largely devoid of antipyretic effects, perhaps because of poor penetration into the central nervous system. The drug has been used primarily as an analgesic in the treatment of osteoarthritis and musculoskeletal strains or sprains. In these circumstances, it is about 3 to 4 times more potent than aspirin. The usual initial dose is 500 to 1000 milligrams, followed by 250 to 500 every 8 to 12 hours. For rheumatoid arthritis or osteoarthritis, 250 to 500 milligrams is administered twice daily. Maintenance dosage should not exceed 1.5 grams per day. Diflunisal does not produce auditory side effects and appears to cause fewer and less intense gastrointestinal and antiplatelet effects than does aspirin. Next question. Glass ionomer placed on rampant caries. Glass ionomer should be placed on rampant caries. Next question. Epulis fissuratum. Epulis fissuratum is an inflamed tissue in rich area to put denture back in. It is due to ill-fitting denture in the buccal phalange area. It is flappy or hyperplastic. It is a flappy tissue on the ridge area. The treatment will be to adjust the denture border and use tissue conditioner. Next question. Why do you take denture out at night? Patients should be told that dentures must be left out of the mouth at night to provide needed rest for the stresses they create on the residual ridges. Failure to allow the tissues on the basal seat to rest may be a contributing factor in the development of serious oral lesions, such as inflammatory papillary hyperplasia, or may increase the opportunity for microbial infections such as candidiasis. When dentures are left out of the mouth, they should be placed in a container filled with water to prevent drying and possible dimensional changes of the denture base material. Okay, important. When dentures are left out of the mouth, they should be placed in a container filled with water to prevent drying and possible dimensional changes of the denture base material. Next question, ectodermal dysplasia. Ectodermal dysplasia is a hereditary ectodermal dysplasia. It is an X-linked recessive condition that results in partial or complete anodontia. Patients also have hypoplasia of the ectodermal structures, including hair, sweat, sweat glands, and nails. Next question: ameloblastoma. Ameloblastoma or dentigerous cysts. Ameloblastoma most likely develop in the wall of a dentigerous cyst. It is a benign but aggressive odontogenic tumor with a high recurrence. Cystic variant is less aggressive and less likely to occur. The solid type occurs in adults of about 40 years old. Common location: the mandibular molar ramus. It is unilocular or multilocular radiolucency. There's three forms: the follicular, the plexiform, and the desmoplastic, which is mostly a favor anterior maxilla. The desmoplastic anterior maxilla. The treatment is enucleation with curettage. So ameloblastoma. Let's read a little bit more about ameloblastoma, and let's go to board busters. Ameloblastoma An ameloblastoma is most likely to develop in the wall of a dentigerous cyst, like we were saying. Okay. Ameloblastoma are tumors of odontogenic epithelial origin and most common epithelial, meaning ectodermal odontogenic tumor. Its occurrence equals the frequency of all other odontogenic tumors. That consists entirely of odontogenic epithelium that shows the differentiation of the familiar histologic layers of the enamel organ sites. Again, it's an odontogenic tumor. Ameloblastoma is an odontogenic tumor that consists entirely of odontogenic epithelium that shows the differentiation of familiar histologic layers of the enamel organ at sites. Enlargement of the tumor may expand the buccal, lingual, cortical plates of bone or palatal bone plates. Resorption of roots or adjacent teeth to the tumor is common, and it may cause, in many cases, an unerupted mandibular third molar is associated with a radiolucent defect. Ameloblastomas are slow-growing, local invasive tumors that usually run a benign course because they do not infiltrate. Often asymptomatic, a painless swelling or expansion of the jaw is the usual clinical presentation. Ameloblastomas occur in three different clinical radiographic situations with different treatments and prognosis. A multicystic ameloblastoma, which is solid, a multicystic, and it represents 86% of all cases and is the more aggressive form that requires more extensive treatment, surgical excision. The marginal resection is the most widely used treatment, and block resection is reserved for larger lesions. Most occur in the mandibule, the molar ascending ramus area. 15% of them occur in the maxilla. The second clinical situation, the second form is on unicystic ameloblastoma, represents 13% of all the intraosseous cases. Most common in younger patients, 50% of them diagnosed in their 20s. 90% are found in the mandibule, the posterior area. Asymptomatic but large lesions may cause painless swelling of the jaw. These lesions are usually treated as a cyst by enucleation and should not be overtreated. Recurrence is common if inadequately treated in an unicystic ameloblastoma. Now, the last one is a peripheral ameloblastoma, which is extraosseous. This is uncommon and represents only 1% of the cases. Arises from rests of dental lamina below the oral mucosa or form basal epithelial cell surface epithelium. Again, arises from rest of dental lamina below the oral mucosa or form basal epithelial cells of surface epithelium. Painless, non-ulcerated sessile or pedunculated gingival or alveolar mucosal lesion. Found in patients over wide age range. Most are middle-aged in 50s. Most common in posterior gingival and alveolar mucosa. What is its histogenesis? May arise from rests of the dental lamina, epithelial lining of the dentigerous cyst, basal cells of the oral epithelium, developing enamel organ, and possibly remnants of the Herdwick's sheath. Consists entirely of odontogenic epithelium that shows the differentiation of the histologic layers of the enamel organ at sites. Its clinical features, most often seen in adolescents, in the mandibular molar area, in the retromolar area. It is the most aggressive odontogenic tumor that is usually benign, but often shows a high expansive and locally invasive mode of growth. Its radiographic features: multilocular or unilocular radiolucent lesion on vital teeth with a soap bubble appearance when the radiolucent locations are large, honeycomb when the loculations are small. Has irregular scalloped margins, appear similar to giant cell granuloma in the mandibule. Microscopically, there is various microscopic patterns of the tumor, include the follicular, which is the most common pattern of the multiple islands with reverse polarity. So there's follicular, there's plexiform, there is cystic, there's acanthomatous, there's granular cell, there's desmoplastic, there's basal cell. Okay? All of them are non-encapsulated. The treatment varies depending on the subtype. Recurrences of common 50 to 90%. If adequately treated, very rarely metastasizes. Periostat and doxycycline inhibit what? Inhibit the collagenase. So the explanation says sub-antimicrobial tetracycline periostat is useful in treating moderate to severe chronic periodontitis. The active ingredient in periostat is doxycycline hyclate. In concert with scaling and root planning, this treatment can be effective in institutionalized older adults. The periostat is contraindicated for those patients with an allergy to tetracycline. These semisynthetic compounds, like doxycycline, were more effective than tetracycline in reducing excessive collagenase activity. Again, this semisynthetic compound, the doxycycline, is more effective than tetracycline in reducing excessive collagenase activity in the gingival crevicular fluid of chronic periodontal patients. So the periostat inhibits the collagenase, the destruction of the collagen. Next question. How do you clean furcation of the previous surgery? Floss, toothbrush, or water? So gingival irrigation performed with an oral irrigator using chlorhexidine diluted to 1/3 the strength. Sorry. Again. How do you clean furcation of the previous surgery? Floss, water, and toothbrush. So gingival irrigation performed with an oral irrigator using chlorhexidine diluted to 1/3 strength. Performed regularly at home and after scaling. Root planning and in-office irrigation therapy has produced significant gingival improvement compared with controls. So gingival irrigation with specialized tips for deep pockets and furcation areas is effective when used daily as part of the home care routine. Use chlorhexidine. The best view of bone defects is with a flap reflection. That's the next question. The best view of bone defects is with a flap reflection. Next question. What type of reinforcement is smiling and praising a child? That is positive reinforcement, i.e., behavior shaping. At every stage of the treatment process, it is recommended to indicate to the child that he is making successful steps in the process of receiving treatment. The frequent use of praise during a child's appointment when the child performs an appropriate behavior is essential. Next question. Acute necrotizing ulcerative gingivitis, ANUG, comes with spirochetes. The characteristics of acute necrotizing ulcerative gingivitis: they are painful, bleeding gingival tissues, blunting of interproximal papillae, pseudomembrane on the gingival margin, in the marginal gingiva, sloughing off, fetid breath, high fever, caused by false fusiform bacilli, which are the spirochetes, Prevotella intermedia, and other anaerobes, most common in teenagers or young adults. Responds well to debridement, oxidizing mouth rinses, and antibiotics. Acute necrotizing ulcerative gingivitis, the gingiva only, low fever grade, must be distinguished from acute herpes infection, which is an ulcer or mucosa in gingiva, and high fever. So when you have an acute herpes infection, you will have high fever and ulcer or mucosa in gingiva. When you have acute necrotizing ulcerative gingivitis, you will have gingiva only, no mucosa, okay, and low grade fever. Prevotella intermedia are also seen in high levels in necrotizing disease. We're going to take a break right there.